I would like all of the various presenters to come back and let's unmute so we can have a discussion and answer some questions. There are a lot of questions here related to diet and how to do primordial prevention. And of course, we have some questions that are starting to come in about the genetic risk score. Let me go first to Dr. Ofili. I know you've done a lot of research and you've included diverse populations in your pivotal trials, but we still are doing poor. We're going to look at some of the newer emerging therapies, and we're just not going to see, in terms of race, ethnicity, sex, gender, social class, the type of diversity that reflects the heterogeneous population in which these new therapies are going to be applied. What do you suggest we do as a society to overcome these barriers?
Thanks, Dr. Ferdinand. My understanding is you're asking about understanding what works for African-American patients. So there actually have been, there's a significant movement out there now on plant-based diets and the benefits, and the studies are recruiting African-American patients. But those are not as many as what's out there, but the data is pretty supportive that African-American patients do well on these diets. Morehouse School of Medicine has done some of those studies. I know your institution has as well. I just think people need to look for studies that have enough patients, population that are underrepresented, to ensure that the guidance they're giving to patients actually would make sense or resonate with the patients.
And since you've done so many studies and have such extensive research history, the other part of my question was, I want you to give us a personal recommendation of what we as a society can do to increase diversity in our clinical trials.
Well, thank you, Dr. Ferdinand. That is just right up my alley. It's what I preach every day, as you know. I was just at the NIH yesterday at a major conference, and it was titled Diversity, Equity, and Inclusion. That was, to me, quite interesting, because it is generally not the type of topic you find at the NIH major CTSA meeting, which are all the large academic institutions conducting research. The bottom line is, I think there is now heightened awareness, obviously, given everything we've all experienced over the summer. But the opportunity, I don't think, will always be there. I think NIH is listening, paying attention. And so this is why we have to be very deliberate and focused in terms of what we are asking. There is no question, as I mentioned in my own presentation, that while the FDA has a FDASIA, all it does is just present what's been done. It has no teeth, there's no enforcement. And so at the end of the day, pharmaceutical companies are going to go to Europe because it's easier to recruit, and the patients are not going to be reflected. At the same time, even NIH, NHLBI, its studies is having to outsource. So I think it will require concerted effort and engagement. Organizations like the Association of Black Cardiologists, the National Medical Association, individuals that are every day seeing these patients come in and out of their practice. We have to engage those individuals. I know you yourself, Dr. Ferdinand, I mean, you've been laboring in that field for a long time, and you've conducted some pivotal studies, studies of statins where you were able to recruit enough African-American patients. So I don't think it's enough to accept that we can't find the patients. And that's what the conference was emphasizing, that it is no longer acceptable to say you can't find the patients. You have to do the extra work it takes, because the patients are there. The communities are engaged, but you just have to go out and identify and work with those communities. So I am optimistic, but I do know that something can be a flash in the pan unless we insist on holding all of us, each other, because I think we're all in this together. When we're talking to an African-American patient or a Latinx patient or an indigenous patient or a person of color, do we actually have the data to reflect what we're recommending to them? And as physicians, we have to go out, and practitioners, I think we have to go out and continue to make the case. It just cannot be people that look like me or you. It's got to be all of us, because there's just a lot that needs to be done.
Thank you. Dr. Roberts, I'm going to come straight to you. We have some diet questions. We have some diabetes questions. I won't forget those. But it really integrates into the genetic risk score. One of the problems with GWAS studies that they've been done mainly in European populations is your genetic risk score equally applied across diverse populations? And will your new study ensure that? Could you hear me, Dr. Roberts?
I can't hear anything.
Okay, well, let's go to the diabetes and diet. Dr. Parapid, in terms of the new studies, are they going to be equally applied? And what is going to happen with the guidelines? We haven't made our way to the guidelines yet. I know there's a 2020 ACC scientific statement or working group report, but not a full guidelines. What do you think is going to happen with the guidelines with these new agents?
Well, I think that sadly, as we have been reading all year long in the past 4 years, we'll be reading semi-statements, meaning that
I do
would
not
be
hear
addressing,
anything, so I cannot answer any question.
we will be still treating actually only populations included in the trials because we don't have enough of anyone besides most likely white middle-aged men.
Yeah.
And I hate sounding like a broken record with repeating Dr. Wenger's thoughts, but there is one thing that I would like to say that I think completely aligns with what Dr. Ofili said, and that is, you know how Dr. Wenger likes to say to educate, advocate, and legislate. Now, we've been educating people like crazy. We've been advocating across all societies, ACC, AHA, ABC, national societies, ESC even. But I think we would eventually have to mandate the same way that you pay a fine if you stand in a place where you shouldn't be parking, you know, no standing or parking anytime. I spent a good portion of my life in Washington, D.C., and don't you dare park where you shouldn't on Reservoir Road. So I think that unless we put it in like the same way we randomize patients, we randomize them by indication. And then maybe good old math, and I'm second generation in my family in biomed research. The previous three were Pfizer, they were in business and banking, and then we all got Bernie Sanders-ish. So the thing is, I think that we will have to somehow mandate, because sadly we have seen it also with trying to mask people up worldwide since beginning of this year, and it's not working unless you slap someone on his wrist.
It certainly can be stimulating that we take some scientific concepts and public health and apply those in cardiovascular medicine. For instance, there were a lot of people saying statins, there was no proof that they were protective in women simply because women were underrepresented in the early statin trials. Therefore, they don't work in women.
They don't work with whomever you didn't give them to. How can we check that if it works? I mean, Dr. Moran just gave an amazing lecture on Women as One Global Initiative. I signed up among, I think, first 5 people in that directory. And I think we should all be signing up in that directory, because only pushing the initiative in our respective all 4 corners of the world, we're going to do something.
Thank you for your enthusiasm in that area of diabetes, women, and health.
Thank you so much.
Belardo, here comes the diet questions. Red meat versus white meat. Should you use nuts at all since they're high in calories? And can you reverse atherosclerosis with a vegan or vegetarian diet? That's what they want to know.
Thank you so much, Dr. Ferdinand. So with regards to, you know, red meat versus white meat, I think that in general, our 2019 primary prevention guidelines, I think did such a great job with regards to emphasizing just totality of the diet. I always tried to tell everyone that no one food in one dose in itself is going to cause disease. I myself have been vegan for 11 years, but I always tell my patients, you know, no one dose of one food is going to in itself cause disease. So of course, when making shifts and looking at overall dietary pattern, if your goal is weight loss, at the end of the day, we can't avoid basic biophysics, biochemistry, and our basic calories in versus calories out. I think what the data shown best for satiety has been protein and fiber are incredibly great for satiety. So I think that's why our ACC guidelines do such a great job emphasizing things that are high fiber, like fruits, vegetables, whole grains, and things that can actually have a lower calorie density. Nuts are perfectly healthful, but when looking for weight loss, always being mindful of calorie density. Just because no matter how healthy a food is, healthful a food is, calorie density still is going to be calories in versus calories out for weight loss.
There was also some pushback because they say that there may be anti-inflammatory benefits of the ketogenic low-carb diet and its potential impact on coronary artery disease, especially small particle LDL.
Sorry, I won't be able
large
to answer
particle
your
LDL.
question.
What do you think about that? These are the audience questions, not me. This is all.
So I think that so the data for ketogenic diets with regards to weight loss have actually not panned out to be superior to other dietary patterns. I do though respect that some people really do like ketogenic diets. Some people find that maybe there's a psychological aspect to it, to the restriction, or the community aspect to it. So far, we haven't found a true metabolic answer in Kevin Hall's metabolic ward studies to show us that it's so superior. But I will say that if someone wants to do a ketogenic diet, which I've had some patients want to do, you can actually do it in a healthy plant predominant or Mediterranean way. So you can actually still be on a low carbohydrate diet, eating fish, eating all plants, eating chia, flax, eating a more plant predominant diet. So there are ways to be on a ketogenic diet if that's someone's dietary preference that actually can stay within the parameters of our ACC recommendations, which is low saturated fat, higher mono and polyunsaturated fat, and things like that.
Thank you. Sometimes clinicians who are vegans will tell their patients, you're a vegan or you're out of my practice, and it sounds like that's not your position.
And I do want to also discuss the topic of veganism within the Black community. Actually, our practice, we have Dr. Sundema Tar. We actually are doing a project now where we want to create Dr. Tar's family's from Liberia. She feels very passionate about expanding plant-based nutrition education to the Black community. So what we're doing now is we're in the grant searching process, fundraising process. Our goal is to create free resources for the Black community, targeted to the Black community, to explain different nuances, some of kind of answering some of the misinformation about vegan and plant-based diets specifically for the Black community. And then our goal is we would love to study the effectiveness of this video series because it's also going to be cost conscious. We have an entire group that are going to be doing grocery store demos, how you can eat plant-based, truly on a budget. And we want to study in a randomized controlled trial and see how patients randomized to this in their after visit summary when they leave the doctor's office versus just standard AHA instructions, if this helps them to change their diet. Because
right. All right, now we're getting short on time. I'm going to request shorter answers from my experts. I know you guys have a lot to offer us. Dr. Roberts might be back in. Dr. Ofili, I'm going to come back to you in terms of diet because I know part of your program is empowering patients to know their numbers and to change their behavior. So you'll be after Dr. Roberts. Dr. Roberts, what I asked you before you lost your sound was Dr. Ofili had challenged us to make sure we have more diversity in our clinical trials. And I was mentioning that many of the GWAS studies typically have been done in European populations where your new genetic risk score be able to be equally applied across populations. And the trial that you're enrolling in, has there been a commitment to diversity? Can you hear me now, Dr. Roberts? All right, Elizabeth, what are you doing with your patients to let them know their numbers and empower them to change lifestyle?
Right. So I think that I certainly appreciate the earlier comments, and the key there is to meet people where they're at. It just does not make sense going to an African-American patient from the Deep South, their ways of cooking. I think it's better to get into a conversation because they too know what's good for them, but getting into a conversation to understand what their food preferences are and how you can make it happen. In terms of the vegan or plant-based diet.
I cannot answer the question even though I
So in terms of the vegan or plant-based diet, they actually, I have patients now, we've got a physician, an internist who specializes in plant-based diet, and her practice is full. They have seminars and people attend. People do make those changes. They all don't go totally vegetarian, as you said, but they can incorporate that into the diet and begin to make change. So for me, Dr. Ferdinand, as you know, part of what we emphasize is it's got to be the totality. Empower people to self-manage themselves. Don't expect them to do anything by rote. And if you actually work with them to monitor, to document, to share that information with you, the dietitian, all the other care team members, there will be change. I'm sure your study will also demonstrate that, because people do like to show off when they're making progress.
All right, Dr. Parapid, gestational diabetes, we now know it's a risk factor for diabetes, and it may also be related to general increase in cardiovascular risk. Do you think the obstetricians and the primary care providers are really clued into that, and what we can do to make that message a little bit more well known?
Thank you so much. It's a passion project of mine. So I think we should just talk more among ourselves, I mean, and with each other, because we tell, at least in different cultures, in different ways, we tell women that everything's going to be fine once they give birth, or I don't know, 40 days postpartum, but these things don't happen. And I think that we have to find the barbershop-like ways to make these women come to us, or at least us try to reach out to them, because we all know, mother or no mother, that once a child arrives, the child is the center of her world, that she simply ceases to exist. So between Danielle, I'm sure can vouch for that. And the thing is, we have to reach out, and maybe everything that we've lived with COVID and surging of the telemedicine is something that we should reach out, because the women of childbearing age nowadays, they wear gadgets, they have smartphones, so we can reach out to them if they cannot reach out to us, to offer a better control of all their risk factors in the long run.
I know if you were in Washington, D.C. for much of your training, you were seeing or experiencing some young African-American women who after birth developed cardiomyopathy. Many times they had preeclampsia, eclampsia, a lot of risk. So there should be some way we can integrate the obstetricians and the cardiovascular specialists to help these women as they matriculate into their older ages.
Fortunately, yes. Our Dean Emeritus, Dean Mitchell, started a program actually that is for all who cannot provide care for them, and they're collaborating very nicely with the DC authorities and Mayor Browser. And we have programs dedicated, although I mentioned earlier, I'm not gonna rain on anyone's parade. DC maternal mortality rates are equal to Uzbekistan, with 37 mothers dead at 100,000 child births with children who survived childbirth. So these figures are horrible. Serbia has same maternal mortality rates like Minnesota, California like Hungary, and that these are data from a paper published in July from the American Journal of Obstetrics and Gynecology. So there's plenty of work for all of us everywhere.
Do you think we have some risk enhancers in women in general that are being overlooked? For instance, autoimmune diseases, connective tissue diseases, other inflammatory
status? We had Dr. Lucas this morning give us an amazing lecture, and I invite everyone who couldn't stay all Saturday long, I fully understand it, to rewatch it. We just have to screen more women, and we have to talk. Dr. Chambers also gave a very nice overview of what our prenatal, the importance of prenatal visits. And I think that we just have to do a better job in primary healthcare physicians' offices, at the level of primary healthcare physicians' offices before they arrive to us. We're the top of the pyramid. I work at the tertiary center. If someone doesn't refer a woman to me when she's planning her pregnancy, I will not see her. So we have
pregnant.
Yes,
Dr.
no,
Ferdinand.
I'm pregnant.
Dr. Ferdinand.
Yes.
Yeah, there was a question in the chat about how elderly people can actually participate with all of the technology. And I did want to share that elderly women are extremely conscientious. Once you take the time to train them, they are the most, they would adhere to the program. My 83-year-old mom, as I put in the chat, is happy to show off her 10,000 steps every day on her Apple Watch. If there's anything wrong with the watch, she makes me, she talks until we go fix it in the Apple store. So please, they get excited about it. Don't dismiss them. I think the worst thing we can do is just assume somebody is not going to do it and you don't even introduce them to the technology.
Well, you know, I've seen your mother, and I've seen you present how enthusiastic your mother has been about controlling her risk, even to the point of paying more attention to her health coach than she does to her esteemed daughter.
Oh, yes.
I'm gonna make another shot at Dr. Roberts. Maybe it won't work. I put in the chat that he could answer by chat whether or not the genetic risk score can be applied across a diverse population. Dr. Roberts, were you able to get back in? No, well, okay. Well, let's go back to diet. There's some more diet coming in. Along with eating more healthy, what about exercise? Since women are at higher risk who don't exercise, as you know, especially in racial ethnic minorities, women tend to even have more obesity than the men. Dr. Biljana, you can go first, and anyone can chip in on that. Do you want to make comments related to activity, not exercise, physical activity as a part of the mix along with diet? It's not enough just to not eat meat.
Yes, no, I agree. I think physical activity, of course, is super important. And I think it's just like Dr. Fink says, just really meeting your patients where they're at. So I think that, you know, when I was training in Temple in residency, my patients lived in they lived in an urban area where with regards to exercise and fitness, you have to take into account, well, where can they exercise? Is this realistic? Can I help give them resources of videos they can do at home on YouTube with the family, things like that, because it depends on the environment. Now I'm in Southern California where I live in an area that's more spread out and there's more outdoor space. So I think as with everything, really just advocating, of course, for, you know, exercise and fitness, but really trying to individualize it to your patient's goals and also their safety and what they're comfortable with and their cultural values and all that's important.
Now, if you were at Temple, and I've been to Temple before, it's a rough neighborhood. So many of our middle-aged and older women, if you say, you know, walk such a number of steps or go take 3 miles, they're not going to do that because other than going to church and the market, they are afraid to go outside. So Dr. Ofili, how do you get around that?
You know, before the pandemic, we actually have all across Atlanta, these senior centers, and then also YMCA. And the thing of it is the physicians are not talking to patients about that. But once you're saying to them, and they're all over town, so they could go up there, they could drive up, and then some of my patients would just be happy to go to the mall and just walk. I think, like I said, this is part of meeting them where they're at. Don't be telling them to go jump on a treadmill. That's not going to happen. And as you say, just going out and walking purposelessly if they don't feel safe, that's not going to happen. But there are ways to do that without even, and some of them now talk about the silver sneakers because they get a good deal on it. I'm not trying to advertise or anything because I don't own any stock in them, but some of my patients will come in, you know what, you're right. I did pay for that. I need to go ahead and use it. And the senior centers are very affordable for them as well.
We're going to have to close, and we could have gone on for a long time. I never was able to really get in touch with Dr. Roberts, but I think we will be interested in seeing how his genetic risk score applies across populations. And Dr. Biljana, do you have a website for vegetarian or vegan diets, if you can give us really quick? And I know the Association of Black Cardiologists, abcardio.org, has
right.
very culturally sensitive meal preparations for African Americans that can be used by anybody. Yep. abcardio.org. Dr. Biljana, you have a website. We only have 15 seconds.
Sorry, DanielleBilardoMD.com, but I also second the ABC Cardio plant-based guide as my favorite.
Okay. Oh, you know about that. Well, how about that?
All the time.
Oh, boy. Well, we had a lot of fun. I'm sorry we couldn't go longer. And obviously, sometimes speaking live is even better than some of the video recordings because there's so much interchange with our colleagues. Dr. Parapid, Dr. Belardo, Dr. Ofili, Dr. Roberts, I hope you can hear me. It was my pleasure, and I'm going to send it back to Rachel.
Thank you so much, Dr. Ferdinand. Great job. Thanks,
Yeah.
everyone.
All right.
Thank you so much, Dr. Ferdinand, and all of the participants. We will find Dr. Roberts at some point during this talk. Now, you honestly, truly shaped really, I think, a really important topic. And at this time, we are going to take a very brief break before we get to our last session. I encourage you to continue to explore our virtual vendors and exhibitors, and also meet us in session 4 at approximately 2:30 p.m. Mountain Standard Time, 1:30 Pacific, 4:30 Eastern, or 3:30 Central. Thank you.